Hello, my name is Julius Wilder, and I'm here with Dr. Kris Kowdley. He is a clinical professor at Washington State University and the director of the Liver Institute Northwest. Thank you so much for joining us here to talk a little bit more about the recent guidelines that you wrote on hemochromatosis.
Thank you.
First of all, could you maybe just sort of generally provide us a little insight around exactly what hemochromatosis is for individuals who may not be as familiar with it?
Yes. So hereditary hemochromatosis is one of the most common inherited conditions among people of Northern European descent. The prevalence of hemochromatosis is as high as 1 in 250 individuals in populations that are enriched of Northern European descent. There is also evidence that there may be other populations that may have other mutations in genes that regulate iron absorption. So this is a very common condition, and testing for it is easily and widely available.
And could you speak to the idea of what the recent recommendations are around screening for hereditary hemochromatosis?
Yes, so I'm one of the authors of the recent American College of Gastroenterology guidelines on hereditary hemochromatosis, and we focus on several aspects, some of which are review, some of which are new. The major new things that have happened is our ability to stage liver disease has advanced significantly because of the use of MRI techniques and, of course, transient elastography.
Yes, sir, yeah.
So liver biopsy, which is very important to identify patients with hemochromatosis who may be at risk for cirrhosis or advanced fibrosis, has become less and less necessary. Whereas in the past, patients needed to be staged because those who had advanced fibrosis are at significantly increased risk for liver cancer and needed to be screened. So we now have inexpensive and widely available screening tests, which I'll talk about in a moment, confirmatory genetic testing, and to estimate and quantify the amount of liver iron and estimate liver stiffness, we have non-invasive tests.
Gotcha. Wonderful. And could you speak to that? What exactly the sort of the way you approach patients in terms of screening and counseling for patients and their families?
Yeah. So first of all, increased suspicion and recognition that patients may be at risk for hemochromatosis is the first step. Like all the liver diseases that we care for, the liver being an organ that has a huge capacity to take insult before forming symptoms, hemochromatosis is the same. So the clinician has to screen for the condition rather than wait for the classic bronze diabetes and heart failure, because those patients are already at a point where they cannot be recovered. But serum iron, TIBC, and ferritin are the first-line screening tests. And interestingly, although ferritin used to be on some chemistry panels, it's usually not. And although serum iron may be on some chemistry panels, it's not always available with an iron binding capacity. So an index of suspicion for hemochromatosis starts with recognition of an elevated transferrin iron saturation greater than 40%. The serum ferritin, which is not very specific, but is quite sensitive for increased total body iron stores, is the next step. So if a patient has a transferrin iron saturation greater than 40%, ideally it should be repeated because there can be a postprandial or after meal increase in iron and accompanied by a serum ferritin. Patients who have an elevated serum transferrin iron saturation, say 45% or higher, should then be assessed for genetic testing for hemochromatosis.
That's very helpful. And when we think about the guidelines that you all just published, and when you think about what you want us to take away, are there highlights in terms of new things in hemochromatosis around HCC or even around PPI that you'd like to share with us today?
Yes. So the first point is that our management of liver cancer from any cause of cirrhosis has changed dramatically, as you know. We now have a whole array of local regional treatments, surgical treatments, and of course liver transplantation. And patients have to be surveyed for cancer before they're going to be identified with cancer, because if we wait for symptoms again, we waited too long.
Yes, sir.
So the first step is to confirm that the patient is a homozygote for the C282I mutation, which is a commonly available test. And interestingly, we now see more and more people coming in with 23andMe or Ancestry.com tests, where they have identified themselves as having the homozygate or compound heterozygote mutation with H63D and C282Y. So counseling is important, and the clinician needs to be able to interpret the test for the patient. Once the patient has been identified as having homozygous hemochromatosis, then the next step is to determine whether or not they're at risk for advanced fibrosis. And this is one of the things that we emphasized in the guideline, because we have the ability now using MRI to quantify liver iron, very well correlated with biopsy measurement, and also we have the ability using MRI to measure liver stiffness. Now, iron can falsely elevate the stiffness of the liver in the absence of advanced fibrosis. So it is a confounding factor, but in most patients, you can get, without contrast, a single MRI giving you those results. And once we have made the diagnosis of hemochromatosis, if the patient does not have a serum ferritin greater than 1,000 at diagnosis, they do not need additional staging for fibrosis or concern for cancer screening. It's only those patients who, on diagnosis, have a ferritin greater than 1,000. We and others have published this many years ago. So, to summarize, serum iron transferrin saturation, if it's greater than 40 or 45%, then the patient should have a ferritin and probably have genetic testing. If they're a C282Y homozygote or compound heterozygote and the ferritin is less than 1,000, they can initiate phlebotomy therapy. Now we can talk in a minute about management. If the patient has a ferritin over 1,000, then it's really important to guess what the fibrosis stage may be, and an MRI scan or elastography would be the way to go.
Yeah, and to your point, with the time we have left, can you speak a little bit to, your recommendations around the approach to management for these patients?
So, not much has changed with regard to management. So treatment is still phlebotomy, which is safe and effective. There is some change in terms of our management with regard to our goal. Historically, we recommended the serum ferritin should be reduced to 50 nanograms per milliliter or less. But we now think that in patients without cirrhosis, a ferritin goal of 100 is sufficient, or 50 to 100. So initial induction phlebotomy treatment is done weekly or at most every other week, and our goal is to get the ferritin to less than 100 or less than 50. Once that's achieved, then the patient enters a maintenance phase, and the maintenance phase is generally characterized by just monitoring serum ferritin and maybe transferrin iron saturation at 6-month intervals. 25% of patients who undergo initial phlebotomy treatment and are iron depleted will never reaccumulate iron. So a substantial proportion of patients will not have enough hyperabsorption of iron to continue to load the liver. Now we do have several interesting observations suggesting that use of PPIs may actually reduce absorption of iron and may reduce the need for maintenance phlebotomy, possibly reduce the need for initial phlebotomy, and possibly forego the need for phlebotomy in some patients. Now, as you know from medical school, the absorption of iron requires acid in the duodenum. Iron has to be reduced from 2+ to 3+ to be absorbed, and so if the duodenal contents lack acid, then iron absorption is less efficient. For the same reason, excessive vitamin C can enhance iron absorption and lead to more iron loading in a patient that is already at risk. So I've had the opportunity to write editorials about this, and this is obviously an area of active interest. Given the concern about PPIs in general with long-term use, I don't think we, in our guidelines or our recommendations, are to actually prescribe a PPI for that purpose. But certainly for patients who are already on a PPI, we do advise them that if they're tolerating it well and they are on it for another reason, it may reduce their phlebotomy requirements.
Well, that's so informative. Those guidelines are really impactful, and that there are a number of issues there that you've spoken to that are new in terms of our management. So thank you so much for your time, and we appreciate you taking the time to come and talk to us.
Thank you. I appreciate the opportunity to review the guidelines with you.